Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a guest that I think we can all learn from her experience. Today I'm going to speak to a Pediatric Emergency Medicine Fellow. Thinking back about my fellowship, it was an amazing, very intense experience. Saw a lot of patients, learned a tons of pediatric and pediatric emergency medicine, and had a very, very, very good learning experience. So I thought it would be a good idea to speak to a PEM Fellow who can teach us from her experience. So today we're going to speak to Sophia, who is a PEM Fellow in Mississippi. Thank you, Sophia, for coming on the show and sharing your experience in pediatric emergency medicine. Let me just introduce you to the people who are listening. Sophia is originally born in China. She grew up, however, in California because she moved there when she was 4. Went to college at Brown University, majoring in biology and Spanish. And after that, went to medical school at Wake Forest in North Carolina, which I happen to be familiar with that place. Almost did a fellowship there. Great hospital, great system. She then proceeded to do her general pediatric residency in Houston, Texas, at the University of Texas, and then continued to her fellowship at the University of Mississippi, Batson Children's Hospital. She is currently a second-year fellow, having a great time practicing pediatric emergency medicine. And she contacted me through the AAP mentorship program a while back. We spoke, and apparently, her being a fellow, she obviously sees a lot of very interesting patients. And I discussed with her if she is willing to share her experience with how she applied the PEM rules or any of the rules. And we spoke and thought it was a good experience to share it with the listeners. So welcome, Sophia. How are you feeling?
Good. I'm excited to be here today to talk about my experience.
Thank you. Thank you for coming. And I would say to the audience, for Sophia's defense, that she's post night call. So if she sounds a little slow, we'll give her a break.
Thank you for that. So the PEM rule that really struck me was one that says it is not the patient's job to prove to us that they're sick. It's our job to prove that they are not sick. And that's one that we frequently apply in the pediatric ER.
All right. So tell us a little bit about that. So that seems to be the rule that everybody, it's rule number 1 for a reason, really.
Mm-hmm.
And I think it's a rule that you don't really grasp as a general pediatric resident. It's something that you kind of learn in your fellowship. That's something that I learned in my fellowship. And I'm glad you know about the rule and applying the rule. Tell us about your experience.
Generally in the ER, we see that for example, for a 2-week-old neonate who has a fever, even if they clearly have viral symptoms, we have this protocol that says we have to rule out meningitis, have to rule out HSV, or for failure to thrive patients, we still obtain lab workup to look for an organic cause, even if the parents already tell us that they've been incorrectly mixing the formula or underfeeding. And in another case, we also apply this rule to patients who have seizure-like activity. And we want to do a full evaluation if this is an epileptic seizure or a non-epileptic, or also known as a psychogenic seizure.
Mm-hmm.
And in many cases, a pseudo seizure or a psychogenic seizure is even witnessed by the medical staff. And to me, the description from the patient and the parent also just sound very consistent with psychogenic seizures. And in these cases, a lot of times we still do a full brain MRI and EEG. We still talk to neuro to prove that this is an epilepsy. And many times that I've done this workup, it all comes back negative, thereby reassuring the staff, the patient, the family that this isn't epileptic seizures. And I was successful in proving that the patient was not sick, not needing anti-epileptic medications at least. So in cases like this, if I already have a strong suspicion that this is non-epileptic, I already have witnesses saying they saw what seems like a psychogenic seizure, why do I still do this full workup and have a specialist follow up with them?
Yeah, no, I agree 100%. I agree with all the above. And I guess that's exactly what this rule is about. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. Translation, prove that this is pseudo seizures, not epileptic. Pseudo seizures do not put the patients at risk. There's nothing serious about them. They have to be addressed, obviously, but there's nothing medical that you need to do, and there's nothing that will put the patient at risk if you don't do. So be it, but it's your job to prove that they're not sick. You can't really do that in the emergency department. Like you said, you need an EEG, maybe an MRI, maybe a neurologist to actually come and see the patient. So if you have the concern, you do what you can and admit them. And I agree the same with what you said about the newborns with a fever. We see that all the time. I encourage my residents and my listeners, if you see a newborn with a fever, the respiratory viral panel is not exactly the answer. You don't need to prove that the patient has a benign virus. Like you said, you need to prove that the patient does not have a bacterial illness, namely SBI, meningitis, pneumonia, etc. Can you share with us the recent experiences you had applying this rule?
Yeah, so in one case, this teenage girl came in after having multiple episodes of seizures over the course of weeks. Her description of the seizures, as well as the one that EMS witnessed that day, all appeared to be non epileptic. But her parents were very persistent and convinced us to consult neurology. And the neurologist on service happened to be one who prefers to admit patients for a full workup. And so when I kind of followed up with her chart, it turns out her MRI and EEG were actually both abnormal. And she indeed was started on anti epileptics. So then my thought was, were we just all wrong? Was I wrong attending the resident? All our clinical judgment was wrong. The EMS staff that witnessed the episode, like, did they just have a lapse in judgment? Which is always a possibility. Nobody's correct 100% of the time. It is also possible that the patient did have a true seizure and an underlying seizure disorder with stress that could lead to both non-epileptic seizures and epileptic seizures as well.
Oh, interesting.
Or it could be like stress from the original seizure may have led to further psychogenic seizures, and she may just have both. Either way, we're not here to prove that she had a psychogenic seizure. We're here to make sure that she doesn't have the epileptic seizures.
Yeah, that's perfect. So that's exactly what this rule is about. I would sharpen it just a little bit more, Sophia, and I agree with everything you said and you did. Obviously, when the patient comes in with a seizure and it's a first-time seizure in a child, in someone that doesn't have epilepsy, I think it's always a good idea to check reversible causes of seizures, namely hypoglycemia, hyponatremia, hypernatremia, things like that. Those are things that, again, rare, but can cause seizures, and you can fix it. So anything that as an ER doctor I can check and fix, I check first. I'm sure you guys did that, but that's a very good application of the rule. And I don't think I realized that there is a relationship between pseudo seizures and organic seizures. I guess there is a relationship.
Yeah, so a patient could definitely have both.
Interesting.
And here's the second story I have is also a teenage boy who came in by EMS for seizures. And the description of the seizure-like events, as well as the one that we witnessed in the ED, all appear intentional. He was like internally rotating his shoulders in this movement that wasn't really jerking, like didn't have the eye deviation, didn't have like the weird shake, tremble, like tonic-clonic movements that we typically see in seizures.
Mm-hmm.
And his demeanor was kind of non-talkative, but seemingly kind of like it could just be teenage moodiness rather than a postictal phase. So again, the ER team felt that this was a non-epileptic teenager, most likely giving us an attitude because he didn't want to be there.
Interesting.
So no, we still consulted neurology, and even after the neurology attending saw him, he told us, "Yeah, that's definitely psychogenic, but get a quick EEG in the ED, and we can get his imaging and follow up with him outpatient." But once we got him hooked up to the EEG, and the neurologist actually saw the EEG, he called back quickly saying, "Actually, he's still seizing, so change that EEG to a continuous one and load him with some Keppra right now." And so that time we definitely all misjudged what we saw.
Very interesting.
Even the specialist misjudged what he clinically heard and saw. So nobody's right 100% of the time. It can be really hard to differentiate between a psychogenic and a psychogenic and an epileptic seizure.
Very interesting.
Yes. And maybe this boy did indeed have some teenage angst going on, but again, that's not our primary job to identify like non-emergent psychiatric mood swings. It's our job to rule out a seizure disorder that could lead to like respiratory depression, neurologic injury, terrible MVCs, or other bad stuff if we don't get it treated.
Excellent. So, yeah, no, I agree with all the above. We're never right 100% of the time, even the specialist. I think all of you guys had a very humbling experience.
For sure.
In a way, I mean, again, thinking about it realistically, you might have saved this kid's life if you have diagnosed pseudo seizures and sent him home, and he would have had a seizure while driving, swimming, etc. Could have been a disaster. So again, perfect application of PEM rule number 1. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. Nobody is going to get into serious troubles from psychogenic seizures or pseudo seizures. But if you let the kid be without diagnosing the epilepsy, and God forbid he or she have a seizure in bad timing, that can be significant, certainly respiratory arrest, hypoxia, etc. So I think good for you for standing your ground. I would say you guys are a little lucky you can get an EEG in the ER.
Yes.
How often do you do that?
Quite often. For the most part, if we suspect it's not a true seizure, we'll get a quick EEG to look at it. If we suspect this is indeed a real seizure that's going to need medication adjustments, a lot of times we just do a continuous EEG inpatient.
Mm-hmm.
But one way or the other, we do it quite frequently for kids who come in with seizure-like activity.
Very nice. That's impressive. And
it helps us dispo kids a lot of times too.
That's great. I mean, I don't think that's I don't think that's a standard of care in many ERs. That's a great tool that you guys are able to use. Fantastic. And again, my approach, Sophia, because I don't have the privilege of getting EEG in the ER. Again, obviously, ABC. I check the glucose, I check the sodium, things that can cause reversible causes of seizures. And then I usually get an EKG under these circumstances. I don't know if you remember, but it's one of my rules. Any seizure-like, syncope-like activity, I think it's always a good idea to rule out any arrhythmias. That is something that will put the child at acute significant risk, and I can speak to a specialist and possibly treat that. So EKG is always a good idea under these circumstances. But if you suspect those are seizures or pseudo seizures, you need to prove that. There's only one way to do that. And great for you for standing your ground and doing that. You applied rule number 1 perfectly.
Yeah, I'm glad to.
And tell me, Sophia, I heard you told me briefly before we started recording, it sounded like you had a very similar experience in your overnight with the heart problem. Is that right?
That is right, actually.
So tell us what happened.
So we had this 10-day-old boy come in with just shortness of breath and poor feeding that just developed over the course of a few hours, and didn't have any fever or viral symptoms. Newborn screen was normal. The glucose check we got was 95, so not looking like a metabolic disorder. Not overall sounding infectious either, so we went down the cardiac pathway as well. And so for us, it was also our job to prove that the patient was well. So we could tell the patient was sick, but we couldn't tell with what. And of course, we wanted to make sure it wasn't one of the most reversible and life-saving causes of a patient being ill. And one of those is congenital heart disease and ductal dependent lesions. So we really wanted to know if this was a PDA that was closing, that was causing his acute dyspnea.
Excellent.
And asked for a stat echo to be done in the ER overnight, which here, if we want an overnight echo, it has to have an indication to be stat. And of course, congenital heart disease with a closing PDA is one of the few emergent indications for an echo.
Absolutely.
And the echo, the cardiology fellow has to come in from home overnight to get that done.
Mm-hmm.
So at 4 a.m. in the morning, everybody's groggy and nobody really wants to go out into the cold and come in and do that. Especially if it's something that they feel like is low on their suspicion, which this cardiology fellow felt that it was. Because overall the kid had good O2 saturations, had a blood pressure in the arm that was pretty appropriate at 98/73. And this baby was thriving and had regained birth weight already. So she was very reluctant to get that done. And just going back and forth with her, I still insisted that she needed to come in and get it done, because even if it's just something low on our differential, it's still something that I need to make sure is ruled out so that I don't miss an opportunity to give something life-saving. When she finally came in and got that echo done, it turned out that this kid did have a ductal dependent lesion and was started on PGE. So I feel very validated this morning.
Very good. Sophia, that's an amazing story. I think you and your team can go to bed this morning thinking you saved a life. You truly saved a life.
Yes.
And nobody, even myself, is familiar and can name and number all the rules, but you applied rule number 100 perfectly. PEM rule number 100 says not all tachypneas are respiratory issues, and not all vomiting means a GI problem. So you saw in front of your face a newborn with tachypnea, with no congestion, no runny nose, no wheezing, no explanation for the tachypnea. You got to think about congenital heart disease. You got to worry and think about giving prostaglandins. Perfect. On a different note, I think many of us had the experience of the child who's coming in with vomiting for days, maybe, with no diarrhea, with no abdominal pain, with nothing to excuse it as a GI problem. And it turns out that the child has a CNS issue. So not all tachypneas are respiratory issues, and not all vomiting means a GI problem. From episode 39, rule number 100. Perfect. I would say perfect job. Excellent.
Thank you. Yeah, babies are tricky.
Babies are tricky, certainly in bronchiolitis season. When you see so many kids with tachypnea that have a viral illness, it's hard to pinpoint that one single patient with congenital heart disease, but you guys did it. Perfect job.
Thank you.
Yeah. So thank you, Sophia, for coming on the show and sharing your experience. Those are really, really great stories that I think all of us in PEM, NPs, PAs, nurses, fellows can really learn from. And as usual, Sophia, I'd like to honor my guest with the outro of their choice. And I guess you like One Republic, is that right?
Yes, that's right.
Right. So I want to be honest, I'm not very familiar with them. I do know one song by them that my wife loves. It's called Counting Stars.
That sounds perfect.
Perfect. So we'll practice. I'll practice Counting Stars, especially for you. And thank you again for coming on the show. Perfect
Thank you
job.
for having me.
Perfect job. Let's keep a log of your patients, and when something like this happens again, we can do this again. I think those are all really great learning experience for all of us.
Yeah, I'll definitely let you know if I have other good clinical experience stories to share.
Awesome. And best of luck with the fellowship and the job search next year.
Thank you.
Awesome. And that is it for today, guys. Thank you very much for listening. I hope you learned from Sophia's experience in pediatric emergency medicine and continue to listen to the podcast. Here is Counting Stars by One Republic. I hope you like it, Sophia.